I am a consultant radiologist. I cover both radiology and nuclear medicine, and the main bulk of the work is related to the PET-CT. We have a 64-slide PET-CT scanner, and we are doing a range of pathologies here. The main bulk of work at Barts Health is hematology, oncology, cancer imaging, lung cancer imaging, and colorectal imaging. The coming trends is for promoting the cardiac PET-CT work and also the neurology work, especially imaging of dementia. Last 1 year had been very productive for us. We have brought in new biomarkers for imaging. We started on with advancements in somatostatin receptor imaging, and we did gallium dotatate PET-CT. After that, we put in 18F fluoride PET to promote the troubleshooting element of molecular imaging. The next agent was choline, and we facilitated the diagnosis of an indeterminate case, and we demonstrated that both molecular imaging and anatomical imaging should work together for the MDT setup, and these new biomarkers should be brought in for the for facilitation of the diagnosis when there is doubt. We recently did our first brain amyloid PET case for the diagnosis of dementia, and we are continuing to work over new biomarkers. The important focus is to synchronize and harmonize our activity with that of the rest of the centers, and that is by way of collaboration and corroboration. We are bringing in research studies so that we demonstrate our work to the rest of the world that we are doing world-class research. We are bringing in new trial reporting criteria to match with the rest of the standards. The main bulk of my work is hematology oncology, and we are using the dual criteria which is already established for response assessment and interim response assessment for the lymphomas. There are new parameters in place which we are validating slowly, but momentum has built up for those criteria, and PERSIST is another reporting criteria which we are exploring at the moment. The work of PET-CT is dynamic, is diverse, and we are finding it a very useful tool for helping the clinician to answer the questions when the imaging modalities do not demonstrate there is pathology. An example would be that the work at Barts is helping out diagnosis of micrometastasis and showing that the functional imaging complements the anatomical imaging. There is a lot of collaborative work going on between nuclear medicine and radiology, and we see it as a way forward for feeding into the PET-MR work, which will be a leading imaging tool in future for research work. This is a case of prostate cancer, and on the right side of the screen you have MRI images, and on the left you have got the choline PET image. The MR demonstrate that there is central gland hypertrophy which is actually in keeping with benign prostatic hyperplasia. We don't see any discrete peripheral nodule, but there is a hypointense area, but it did not show any restricted diffusion. Although this patient had lymph nodes, there was a question of whether there is disease in the prostate gland and whether the lymph nodes demonstrate metastatic disease. This is the choline PET, and that shows there is focal increased uptake in the left peripheral zone. So this actually adds to the information given on MRI and facilitates that there may be a prostate cancer at this site. This patient also had nodal disease, which was very mildly avid, and that was in keeping with inflammatory nodes. So the overall, when we combine the two modalities together, they are helping in staging the process, and these anatomical and functional tests act as a triage test for the surgeons, for the oncologists, whether they want to treat the patient surgically or with chemotherapy or radiotherapy. Another area of interest is evaluating the concordance and discordance between the anatomical and functional imaging. It's important for clinicians to know what do they do when we give them conflicting information. That the advanced imaging modality like MR is demonstrating one process, and on the other hand, the functional imaging, for example PET, may demonstrate discordance with what MR shows. The answer is very simple. MR is far superior than any of the other imaging modalities to demonstrate anatomy. Surgeon without information of the MR, I don't think that it would be a good idea to operate a complex case like a colorectal MRI. The question of discordance is better understood if we look at the cancer pathway. There may be more than one processes which is contributing towards the development of cancer. Secondly, the PET scanner PET imaging which we are doing, it may be showing the cells which are abnormal but yet have not formed an anatomical change. So it depends where we use both MR and PET. Essentially, if it becomes a red light that this is cancer, then we have actually missed the boat. We should pick it up before it has actually formed the cancer. So both actually complement each other. The vast majority of discordance we are seeing is with somatostatin receptor imaging and MRI. Can somatostatin receptor imaging replace MRI? No. Can MRI replace somatostatin receptor imaging? No. The answer is a simultaneous PET MRI or a sequential PET MRI model that both complement each other to answer the questions which the clinician have. At present, there is a lot of work going on about the SUV correction for the PET MRI. The simultaneous model is using Dixon-White sequence, which defines the edges very nicely with some variation in the SUV values. Pediatric cases, PET MR is far superior because there is less radiation dose. Lung cancer, on the other hand, PET CT provides very useful diagnostic information which complements the information already available on the CT scan.